All right, so welcome again. Just to make sure you are in the right space, today's topic is on updates in 2025 on breast and prostate treatment. And so our presenter today is Dr. Michael Herman, who is a medical oncologist at OTMH since 2020. And we are super pleased to have him online today. So Dr. Michael, I will pass it over to you.
Thank you so much. I'm happy to participate and have the opportunity to help share. A lot of my patients have gone to Wellsprings in the past, so happy to help give back in some way. So really, the purpose of this presentation was to present to a patient audience some of the updates in breast and prostate cancer to think about in Canada, as well as some of the other things that are important globally around cancer care in Canada from the perspective of a medical oncologist, which is what I do. So my objectives for today were to first discuss some of the cancer trends in Canada in the last decade or so. I was then going to spend a bit of time talking about the diagnostic and screening process of cancer and some of the advances there, and then get into some of the emerging treatment options, both from a surgery radiation perspective as well as medication treatments for breast and prostate cancer. Um, Fortunately, a lot more patients these days are surviving their cancer, and so I wanted to discuss some issues surrounding survivorship, which is what happens after all the treatments are done, and then talk about the importance of really a team-based approach for looking after patients with cancer, multidisciplinary care, as well as all the allied health practitioners we rely on to be able to support patients. And then talk about finally some resources available in the community for patients. Um, so in terms of trends of cancer in Canada, unfortunately, cancer cases have been increasing. And this is really a function of, growing population in Canada as well as an aging population, and then the fact that unfortunately rates of cancer diagnosis are higher in older individuals. Um, so the number of cases that have been diagnosed have been going up, but fortunately the mortality rate from cancers have been going down over the years as the treatments have advanced, which is great. In terms of the prevalence of different types of cancers in Canada, about half are consisting of breast, prostate, and colon cancer. And so that's really, I think, why the focus was more on the breast and prostate cancer cases in this talk, because it does make up about 40% of all uh, cancer prevalence in Canada. So it is the most common. Um, and just kind of similarly to what the previous slides were showing is that although, the number of cases have been going up, the red lines show that the number of deaths and mortality rates have fortunately been going down because treatments have been generally improving over the years, which is great. Um, so how is cancer diagnosed? Well, the two main ways are through screening programs or for cases that are not picked up from screening, really through a symptom. So like a patient notices a new symptom or a new mass or something had changed that makes them then go to see a healthcare practitioner, which then leads to the diagnosis. Um, Obviously, screening can be helpful if it can help to try to diagnose cancers at an earlier time point and perhaps an earlier, more treatable stage. And so that's why a lot of efforts have been put into um, rolling out screening programs for different types of cancers. For breast cancer, screening traditionally was in the age group of 50 to 74. But just last year, they opened it up actually as well as an option for patients age 40 plus. And that was because there was some evidence that had come out that starting cancer screening at a younger age, under 50, can potentially pick up more cases in that younger age group and improve outcomes. The difficulty with cancer screening for any type of cancer is that it's a balance between trying to pick up more early stage cancers, which can potentially be treated successfully, versus the fact that unfortunately there is always like a false positive rate associated with screening tests. So there may be changes that can get picked up with screening tests that can lead to anxiety and further tests like biopsies, but turn out not to be cancerous. So that is like a potential downside to consider with screening. Um, Traditionally for breast cancer screening, it consists of mammograms every 2 years. And there is also a high-risk Ontario breast screening program, and I think other programs in different provinces that are available that include a little bit more intensive screening, sometimes with MRIs, particularly in the higher risk patient population. So those with like a genetic mutation or a significant family history of radiation to the chest, where they could be eligible for that. For prostate cancer screening, there's actually not really a standardized protocol in a lot of places. And that's because the evidence surrounding like PSA, which is a blood test that can help pick up prostate cancer, is a little bit mixed on how actually useful that is compared to all the false positives that can come along with the having a slightly high PSA and the tests needed to diagnose prostate cancer. Um, so a lot of the guidelines now basically just suggest that patients should just kind of have a conversation with their family doctor, particularly between the ages 55, 69 for prostate cancer, to talk about whether it makes sense for them to consider prostate cancer screening, what the risks are, consider doing a PSA, as well as a digital rectal exam, which is the physical exam way to help pick up prostate cancer. There is some evidence that maybe doing screening a little bit earlier, even in the 40s, could be helpful for patients who are at higher risk for prostate cancer, which is if you have a family history of cancer or in Black men, there's some evidence that that may also be helpful. Um, there are a number of different standard tests that are out there that we can do to help diagnose cancer, as well as kind of stage. And staging is really important to try to figure out the extent of the cancer, whether it's just in one area or if it had spread to a lymph node or other areas of the body. So those tests can be things like mammogram, ultrasound, MRIs, CT scans, bone scans, and of course biopsy to make the diagnosis. And increasingly, we're also using other tests, like, for example, a PET scan. A PET scan is really using like a radioactive dye or tracer that it can sometimes be a little bit better at localizing to where the cancer is, either through certain antibodies and receptors on the cancer cells, or through dyes that kind of go to where glucose or sugar uptake is high, which can be high in cancer. So there are specific criteria that are out there when the PET scans can be used and when they're funded, but it has become a little bit more common for the diagnosis and staging of different cancers. Um, uh, Genetics is also something that we think about now, alongside diagnosis of different types of cancers, because there are certain mutations in certain genes that can raise risks for developing different cancers, including breast and prostate cancer. And the estimates are that about maybe 5 to 10% of patients with breast or prostate cancer have some kind of gene mutation that raises the risk of developing that cancer. And the reason we test for these genes is because it can have implications for whether other family members should get tested, what kind of cancers the patient or family member should be screened for in the future. Sometimes there can be preventative surgeries, for example, like BRCA mutations in breast cancer. Some patients choose to get preventative breast surgery, like a mastectomy or ovarian removal, because it can be associated with ovarian cancer as well. And then it can also sometimes affect even the drug treatments that are used for treatments of different cancers. There are specific situations and criteria that often the government will use to cover to decide whether these genetic tests will be covered, and often it's a blood test that would pick up these mutations, and they tend to be reserved more for people with like a higher risk, so more of a family history of different types of cancers. But there is also private pay testing available in the community as well. And it is important if a gene is picked up on these tests that patients then go on to get some genetic counseling with a genetic counselor about what that means and what the implications are. So moving on to the actual treatment of breast and prostate cancer. For breast cancer, when it comes to surgery, a lot of the advances in the last couple of years have been using different kind of localizing techniques. So using, implants or seeds at the time of biopsy to localize where the cancer is, so that during the operation, the surgeon can have an easier time of knowing exactly where the cancer is and trying to only take out the area of cancer and minimizing kind of damage to surrounding tissues. There's also been a lot of studies into actually trying to de-escalate surgery. So traditionally, for breast cancer, in addition to removing the cancer in the breast itself, patients would often get a lot of lymph nodes from the armpit removed because that's a common area that breast cancer can spread. But there's been studies showing that in certain situations and populations that perhaps we don't have to take as many lymph nodes out, or even avoid taking any lymph nodes out, which can be helpful because if you have a lot of lymph nodes removed, then it can have some complications like swelling or edema in the arm. For radiation, there's been a move to trying to shorten radiation schedules, so only doing 3 or 4 weeks instead of kind of 5 or 6 weeks, which it has been traditionally. And there's been some studies and evidence showing that, the outcomes are just as good. And there was a move to do that during kind of the COVID pandemic, but that's also continued to today. When it comes to prostate cancer surgeries, there's been a move to using robotic assisted prostate surgery, which only certain centers have because of the cost of the equipment. But it's trying to make the surgery a little bit more kind of minimally invasive, perhaps quicker recovery times, and less chance of complications. Radiation is kind of the other main treatment for a localized prostate cancer, and that can include external beam radiations where you're lying in a machine and having external X-rays targeting the prostate cancer, or brachytherapy where there's actually radioactive kind of seeds inserted into the prostate cancer. And there's something called stereotactic radiation now, which is a more focused, much more focused type of radiation, where they're able to kind of target a more specific area with higher intensity to try to reduce the side effects of radiation damage to surrounding areas. So that's kind of the surgery and radiation side. When it comes to pharmaceuticals or medications, really the big shift in breast and prostate cancer, but also all types of cancers, is that that treatments have become much more personalized. So it's no longer, one size did not fit all for these types of treatments. We really need to individualize our treatments now to the individual patient's cancer, because we know now that even within breast or prostate cancer, there's a lot of variability on the types of markers that exist within the cancer cells, kind of that would affect the prognosis and what the best treatments are. So we need the biopsy and our help from our pathologist to really know what the markers are on the cancer to be able to pick the best type of treatment. For breast cancer, the three or four main groups of treatments, again, depend on the markers on the cancer cells. They can include endocrine therapies because we know some breast cancers respond to kind of estrogen in the patient's body to grow. So there's a lot of treatments out there now looking at how to block the estrogen, um, either on its own or with other medications to try to treat that. Chemotherapy has been our traditional treatment that we've been using for a long time now in certain indications for breast cancer. But there's more targeted therapies that have come out recently. So trying to use antibodies, which are specific to certain markers on the cancer cells, such as trastuzumab or Herceptin, which goes towards a marker called HER2, which is a kind of a subgroup of breast cancer. And there's newer treatments that are basically antibodies that are attached to drugs. So if you can see in the picture, you take an antibody targeted towards the cancer cell, and it's kind of linked to a chemotherapy drug. So it's basically trying to target the chemotherapy more towards the cancer cell, so it gets into the cancer cell and um, kills the cancer cell, but trying to limit the damage to like the normal body cells in the rest of the person. So that's been an advance. There's also some oral drugs now that are also more targeted, depending again on the markers on the cancer cells that can be used. And immunotherapy is a treatment that's basically tries to activate your immune system to go after cancer cells. It's been used a lot in different types of cancers like lung cancer and melanoma. There are certain types of breast cancer where it can be used, particularly triple negative breast cancer, which is like a more aggressive type. There's some indications where immunotherapy can be used there. And then finally, it's important to have involvement with the clinical trials and research so that we can try to advance our treatment options that we have for patients. When it comes to prostate cancer, so kind of similar to breast cancer, a lot of these cancers are kind of driven to grow in response to hormones in the body. So a big mainstay of our treatments that we have for prostate cancer involves trying to actually lower that testosterone level as a treatment for the cancer. So there's hormone injections that are out there called androgen deprivation that can be given every, 1 to 4 months. And then there's newer pills, which also block the testosterone that are a little bit more targeted and stronger that have been shown to kind of improve the outcomes when we add those in. So oftentimes now we will think about adding in a hormone blocking pill into addition to the hormone injections. There is still a role for chemotherapy, which has been used for a while for prostate cancer. But there are now starting to develop some more targeted therapies similar to breast cancer, like pills. And there's even a newer treatment called lutetium, which is like a radioactive drug that is targeted through an antibody to try to go towards the cancer cells and deliver some targeted radiation kind of within the body just to the cancer cells. And so you can see over the last couple decades, the number of drugs that have been approved for prostate cancer have been really increasing, which is great to have more options for patients. And more patients are doing well with cancers and being cured. Unfortunately, not everyone is cured, and we're trying to work on that with all the research that's being done. But the number of patients who are long-term survivors is improving. And with that comes a lot of other issues that can happen after going through all these treatments that affect survivors of cancer. So there can be physical complications from treatment like tiredness, brain fog or chemo fog. You can get kind of a decreased concentration from some of the treatments. Pain can happen. There can be some sexual dysfunction, a neuropathy, so like numbness, tingling in the hands and feet, bone thinning with certain treatments, particularly the hormone blocking treatments. There's a risks of cardiovascular problems or even earlier menopause for some patients that undergo chemotherapy. And of course, there's a lot of psychological and emotional concerns going through cancer treatment, anxiety, depression. There can be body image concerns, strains on relationships because of how stressful it is, as well as spiritual distress. And then there can be social isolation, employment and financial strain because of the burden of additional costs and time that needs to be taken off to get through all the treatments. There's a lot of health disparities that have been well described in studies. Even though we live in Canada and there is for the most part universal healthcare, it's still not perfect. Um, and then there can be long-term health concerns. So the stress of surveillance. So after going through treatment, having to kind of come back and do all these follow-up tests and the uncertainty surrounding that. Health promotion. So um, uh, taking into account everything else you can do after all the treatments are done to try to improve your health, like exercise, diet, and smoking, alcohol use, and then just dealing and coping with the uncertainty. Because unfortunately, after patients go through all these treatments, uh, oftentimes we can say that they're in remission, but they still remain at risk often for recurrence. And so there is still, unfortunately, a lot of uncertainty that can exist even after you go through all the treatments. Um, a lot of cancer treatments can also have fertility impacts, and this maybe applies a little bit more to breast cancer, where patients can be diagnosed at a younger age, whereas for prostate cancer, a lot of times it is diagnosed at a little bit of an older age. But radiation, chemotherapy, hormone therapies can all affect fertility. So it's important to discuss with the healthcare team um, about family planning. And there are specialized fertility clinics that are out there that can help with things like sperm making and egg harvesting and freezing. And there can also be some medications that can help reduce the effects of fertility from the treatments. And so because of all these things that are important in treatment of cancer, it's really important to have like a multidisciplinary team. So not just the medical oncologist, which is what I do, but also like the surgeon, the radiation doctor, the radiologist who reads the scans, pathologist who reads the biopsies, primary care providers are so important. And then there can be things like the genetic counselor, which I talked about, the research team, physical therapy, patient navigation, social work, nursing, the dietitians, and patient support groups. So we all try to work together as best we can to help support patients. And outside of just the doctor team, there's a huge other team of other allied health supports that we need to help support patients. So as I said, kind of the nursing team, pharmacy, dietitian, social work, physiotherapy, occupational therapy, counseling supports, massage therapy, and dentistry, because of all these different aspects that cancer and going through the treatment of cancer can have on patients. So really important to have supports from other team members. There's also a number of resources that are out there in the community. Particularly like in Ontario, but in the rest of the country, Cancer Care Ontario has some online resources on management of different symptoms that can come along from treatment of cancer. So things like tiredness, things like nausea, constipation. There are some guides out there that can be helpful to how to manage those things. Patient support groups. To try to get more involved with the community and get more support from the community. So there's Cancer Connection, the young adults with Cancer Canada group is really helpful for the younger adults that get diagnosed with cancer. And then community supports, of course, this is a Wellspring talk. So, there's lots of other information that I'm sure will be provided from Wellsprings on all the supports that are offered to help patients with their journey. Financial support is a big one because even though a lot of times like some of the drugs will be covered, like chemotherapy, There can be other drugs like the take-home prescriptions that may not necessarily be covered, and just taking time off work. So there is a guideline through UHN, which I've copied here, the University Health Network, that has some of the things to think about from a financial support perspective, but also just important for patients to kind of ask their team members, and often social work can help with finding information on kind of financial support programs that can be out there. Psychosocial supports. Wellsprings, as I mentioned before, has them. Gilda's Club, Coping with Cancer. And then oftentimes for our patients, transportation can become a bit of an issue because we may be seeing them quite often, like, either even every week or every 2 weeks. And so coming back and forth to the hospital for all the appointments can really add up. So there are some programs such as Wheels of Hope, which is a volunteer based, but helps provide some transportation for patients to get back and forth to their appointments. And the Canadian Cancer Society website is also a good resource because you can kind of enter your immediate location and look up some more local support services that may be out there.